These inhibitors in the hematology practice, it's now, I would say, a burning issue because these kinase inhibitors have become quite widely available at rather a bit cheaper cost, I would say. So, what is a kinase? A kinase is an enzyme that catalyzes the transfer of phosphate groups from high energy phosphate related molecules to specific substrates, particularly to activate the later. And this is the human kinome. This is the human kinome, and it contains so far 538 kinases have been discovered, and they are regulated by 2% of the entire human genome. And this is the tree. Here lies somewhere. There are actually 4 broad categories of kinases. I am not going to details. This part of the tree comprises the tyrosine kinase, and Jenus kinase is one of the tyrosine kinases. So, and protein kinase, they are divided into 3 types: serine-threonine kinase, tyrosine kinase, and dual specific kinase, which are specific for both serine-threonine and tyrosine. And our today's the topic, this Jenus kinase is one form of this tyrosine kinase. Okay, sorry. Okay, the pointer is not possibly working here. So there are this Jenus kinase is a family of intracellular non-receptor tyrosine kinase that transduces cytokine-mediated signals via the JAK-STAT pathway. And there are 4 types: Jenus kinase 1, we call it JAK1, JAK2, JAK3, and tyrosine kinase 2, that is called TYK2. And here you can see this is the head of the Roman god Jenus. It has 2 heads. This is the younger head that stimulates transition. Jenus is a god of transitions, and the older head, like us, it tempers down the transition, slows, regulates it, or tend to control it. And similarly, okay, sorry, where is this? This is the, this is the Jenus kinase. This is a typical 4-dimensional picture of Jenus kinase. Okay, thank you very much. Thank you. And okay. Yeah, this is one moiety. This is a heterodimer. This is one moiety, and this is the other moiety. This is the younger moiety that tends to phosphorylate, and this is the older moiety that tends to control phosphorylation. And that is why, just because of, not only because of the aesthetic structure, but also because the dual in between contradictory function of the 2 moieties, this has been very intelligently named as Jenus kinase. And this is the JAK-STAT pathway. We can see here. This is the this is the cell membrane, and these are cytokines like TNF alpha, interleukin 6, all they attach to the cytokine receptor in the cell surface, and it leads to activation of the Jenus kinase inside the cytoplasm. And this Jenus kinase, in its turn, phosphorylates the STAT, signal transducer and promoter of transcription. This STAT, it transduces the signal to the inside of the nucleus and also attaches to the DNA, and thus de-repress the DNA, particularly pro-inflammatory genes for synthesis. And now I shall show some differentials. I say that there are 4 types of Jenus kinase. JAK1, it is mainly involved in inflammation, granulolysis, and neural survival. JAK2, erythropoiesis, myelopoiesis, platelet production, and inhibition of thrombosis. JAK3, growth and proliferation of T cells and NK cells, and TYK2, beta cell differentiation, T cell maturation, and antibody production. So now we can see here. These are first generation JAK inhibitors, prophylactically, parasitically, and pathically. They are broad spectrum. This one acts on all JAK 1, 3, and 2, parasitically JAK1, and these are later generation. As I have mentioned earlier, this JAK2 is mainly responsible for hematopoiesis and inhibition of thrombosis. So these are the molecules, prophylactically, parasitically, which can cause cytopenias and also thrombosis. Now, what are the ingredients? My topic is judicious use of kinase inhibitors, and there are actually multitude of ingredients of judiciousness, but I shall highlight here only these 4 categories, 4 attributes of judiciousness: patient selection, patient preparation, attention to drug-drug interaction, and monitoring. So, now patient selection. What is just before we we decide to administer JAK inhibitor to some patients, we have to consider what are the absolute contraindications. We must abide by them: pregnancy, breastfeeding, and patients contemplating pregnancy, active infections such as tuberculosis, hepatitis B, hepatitis C, HIV, active or recurrent herpes zoster despite zoster vaccination. There is such category of patients. Of course, this vaccine is not available in country. And history of recurrent severe infection or frequent hospitalization from serious infections. These are absolute contraindications. Active malignancy or a history of several multiple cancers in the past. Ongoing mandatory treatment with other immunosuppressive, because true immunosuppressive can cause further immunosuppression, dangerous effect like transplant patient. Severe organ failure such as decompensated cirrhosis and end-stage renal disease requiring dialysis. And this is the category in which they are not absolutely contraindicated, but you should be very cautious in giving these patients like age above 65, cardiovascular diseases or the risk factors, history of malignancy, even single malignancy, except treated non-melanoma skin cancer, infections, risk for GI perforation, for example, diverticulitis, or past history of GI perforation, lymphopenia. These are relative contraindication. And in case of thromboembolic disorders, anemia, thrombocytopenia, we can use selective JAK1 inhibitors like upadacitinib and filgotinib. And here we have to remember, now actually many of our doctors are prescribing JAK inhibitors to wide range of autoimmune conditions, even some non-autoimmune conditions. For example, I came across one prescription by a gynecologist for dysmenorrhea. The gynecologist has prescribed tufafinib, one tablet thrice daily, and another dental surgeon prescribed tufafinib for relief of acute dental pain. So these are not painkillers, and we have to remember that not JAKs are JAKs of all types. So tufafinib, these are the label indications which have been permitted by US FDA, and these are off-label, or there are some research from them. Tufafinib and upadacitinib are nearly similar, quite wide range. Rheumatoid arthritis, axial spondyloarthritis, psoriatic arthritis, polyarticular GIA, and off-label SLE, Takashu, systemic sclerosis, and CPILD. Filgotinib only for eye, so far recommended, and ongoing phase 2 research in axial spondyloarthritis and psoriatic arthritis. Deucravacitinib, this is a TYP2 inhibitor recommended for only psoriasis, but there is some promise about psoriatic arthritis and also systemic, particularly cutaneous manifestation systemic, lupus erythematosus. Now suppose the patient has got a disease for which JAK inhibitors are indicated. Should we still go to the JAK inhibitor? What nowadays many doctors are prescribing, whenever they diagnose rheumatoid arthritis, they start JAK inhibitor. So let us see what is the recommendation of EULAR 2022. This is the latest. First, in the phase 1, we have to start methotrexate. You have to increase the dose to its maximum recommended dose, and if it fails, then you should consider biologics or not a JAK inhibitor. This is not the first drug. So after failure of the CS demand, or what we call conventional synthetic disease-modifying drugs like methotrexate, sulfasalazine, leflunomide, we can consider. So what should be the dose of methotrexate? You can see a satisfactory response requires 18 to 25 mg per day. Just I am highlighting this because I have seen many doctors are prescribing, JAK tufafinib after failure of 15 mg of tufafinib, and may require escalation to 30 mg subcutaneously weekly. So, and what should be the route? The subcutaneous route is superior in efficacy to the oral route. So, what do we mean? Inadequate response of rheumatoid arthritis to a CS demand. How inadequate response is defined? Failure of reduction of DAS28 by at least 50% at the end of 3 months. And in case of methotrexate, the patient should be receiving at least 20 mg of methotrexate during the last 4 weeks. Or failure to achieve the target DAS28 less than 3.2 at the end of continuous use of 6 months. And last 2 months at the highest dose. In case of methotrexate, 25 to 30 mg and preferably subcutaneous route. So, and same is the recommendation for psoriatic arthritis. First, for psoriatic arthritis, within 3 months, first treatment is NSAID and local injections. Second phase, methotrexate or other CS inhibitors, and in the third phase comes JAK inhibitors. Now, these are for patient selection. We must be very careful in selecting patients. Now, patient preparation. For when we consider patient preparation, our topmost priority is prevention of infection, because infections are the complication that makes the life of a recipient of JAK inhibitor hell. So we must carry out a thorough screening basically primarily a clinical screening for infections and malignancies. Clinically, for focused symptoms and signs, we have to examine skin, nail, lymph nodes, epididymis, vertebral column, and oral infection. Chest X-ray, quantiferum typical plus or tuberculosis test, and other, and also investigation for other identified foci. Hepatitis virus like hepatitis C, hepatitis B, and if there are some indication, we have to carry out the HIV test also. Treatment of infection is present, and we have to vaccinate the patient, and finally, last but not the least, we have to educate the patient. And for preventing infection, we have to encourage physical activity because physical exercise, increases immunity, maintenance of optimal nutrition, maintenance of good personal hygiene, particularly oral hygiene is very much important. COVID-19 principles including hand washing, distancing and mask, and optimum control of diabetes. Vaccination, as recommended for adult vaccination. Actually, there are recommendations for adult vaccination in many countries, including India, but there is no such in our country, particularly influenza. Annually, preferably in February, March, because in our country, the influenza season spans from April to August. Pneumococcal vaccine initially you have to give conjugate, that is PCV13, MMR 13 or Prevnar 13, and after 2 months we have to give polysaccharide vaccine like Prenovax or Pneumo 23, 8 weeks after PCV. But if you mistakenly if you give polysaccharide vaccine first, you have to wait for 1 year for giving the conjugate vaccine. Hepatitis B, human papillomavirus, and herpes zoster vaccine. What to do if quantiferum typical or tuberculosis test is positive? It is a very important question. We have to make a clinical review because giving a patient treatment for latent tuberculosis, that is 2 drugs, rifampicin and NH only for 3 months, to a patient in whom there is active tuberculosis, it is a gross crime. It is I would say it is a very big crime. So we have to make a clinical review. We have to take the history of cough, feverishness, anorexia, weight loss, profound fatigue. If cough is present, we have to test sputum. If the cough is unproductive, we have to test induced sputum for AFP, gene expert, MTB and TMDNA, particularly if the patient has been immunosuppressed before that also, and mycobacterial culture. And if cough is absent, we have to do CECT of chest, if provided these 4 features are present. And we have to re-examine the lymph nodes. On my first examination, we may miss it. We have to examine spine for gibbous, breast, liver, spleen, and epididymis. How should we treat a patient with latent tuberculosis infection or LTBI? In Bangladesh, it has been named tuberculosis preventive therapy or TPT. Now it is being given by all the tuberculosis centers. And the preferred options are, 3-month isoniazid plus rifapentine given once weekly, and the recommendation is strong. Evidence of efficacy is moderate. You can see this is what it is being given by governmental agencies, ICDDLP, and also GRAC. And this is also another preferred option. 4 months rifampicin given, only rifampicin monotherapy for 4 months. It is actually recommended for who could not tolerate INH or those who have HIV, because anti-HIV drugs, some of these drugs have interaction with isoniazid. Now we have to pay attention to which other drugs the patient is receiving from all sources, irrespective of specialty, from ENT, from gynae, from other, dermatology. We have to pay attention to all the drugs, not only a history of anti-rheumatic drugs. And the first one is synergistic immunosuppression. The kinase inhibitors enhance immunosuppression with other immunosuppressive agents and should not be combined with prednisone more than 20 mg per day, cyclophosphamide, azathioprine, leflunomide, cyclosporine, tacrolimus, and mycophenolate mofetil. I should give warn you repeatedly. I have come across many prescriptions containing profacitinib plus leflunomide. It is a dangerous combination. Vaccine efficacy. Do they do anything with vaccine efficacy? We have to avoid live vaccines, and actually all the kinase inhibitors reduce the efficacy of the vaccine.